Radiation therapy plays a crucial role in treating malignancies that involve the entire body. One of the most complex techniques used is the cranial-spinal irradiation. In this video, we will break down the essential steps in this setup process and how each component ensures precise and effective treatment.
Among the many types of cancers affecting the central nervous system, medulloblastoma stands out as the most common malignant brain tumor in children. It arises from the cerebellum, the part of the brain responsible for coordination and balance. Unlike some brain tumors that remain localized, medulloblastomas tend to spread through the cerebrospinal fluid, affecting the spinal cord, making their treatment particularly challenging. The exact cause of medulloblastoma is not fully understood, but research points to a combination of genetic mutations and environmental influences. Some cases are linked to syndromes such as Gorlin syndrome or Li-Fraumeni syndrome, both of which involve mutations in tumor suppressor genes. However, for most patients, there is no clear hereditary pattern. Environmental factors such as exposure to high doses of radiation have also been explored, but no definitive external cause has been identified. Medulloblastoma is a rare cancer, but it accounts for about 20% of all pediatric brain tumors. It is the most common in children under the age of 10, with a peak incidence between 5 and 7 years old. While it can occur in adults, pediatric cases are far more frequent. There is also a slight male predominance, meaning boys are more common to be affected than girls. Because medulloblastoma tends to spread through the cerebrospinal fluid, treating only the primary tumor site is not enough. That's why cranial-spinal radiation plays a crucial role. This treatment involves delivering radiation to both the brain and entire spinal cord to eliminate microscopic tumor cells that may have traveled beyond the original site. Central nervous system lymphomas are rare but aggressive cancers that develop in the brain, spinal cord, and surrounding membranes. These tumors can either originate in the CNS as primary CNS lymphomas or spread from systemic lymphomas such as secondary CNS lymphomas. While the exact cause of CNS lymphomas is not fully understood, several key factors contribute to their development, including genetic mutations, immune system dysfunction, viral infections, and chronic inflammation. At the genetic level, mutations in genes are found mostly in primary central nervous system cases. These mutations triggered by uncontrolled B-cell growth by activating key survival pathways. Other genetic alterations prevent lymphoma cells from undergoing normal cell death, allowing them to multiply unchecked. A weakened immune system is one of the strongest risk factors for CNS lymphomas. In HIV patients, primary central nervous system lymphomas is considered an AIDS-defying illness, often linked to Epstein-Barr virus. Similarly, individuals on long-term immunosuppressive therapy after organ transplantation face an increased risk. Even in otherwise healthy individuals, age-related immune decline may contribute, which explains why primary central nervous system lymphoma is most common in adults over 60. Beyond immune suppression, viral infections, particularly Epstein-Barr virus, are linked to CNS lymphomas, especially in immunocompromised individuals. Epstein-Barr virus infected B cells can transform into cancerous cells, driving growth. Chronic inflammation, as seen in autoimmune diseases like rheumatoid arthritis and lupus, may also contribute to CNS lymphoma risk, particularly in patients on long-term immunosuppressive drugs. Environmental exposures such as prior radiation therapy to the brain or possible exposure to pesticides and industrial chemicals have been suggested as potential risk factors, though more research is needed.
Although rare, the incidence of CNS lymphomas have increased over the past few decades, particularly in older adults. Let's explore the epidemiology, including incidence, risk factors, and survival rates.
Primary central nervous system lymphoma accounts for 2 to 7% of all primary brain tumors and 4 to 6% of all extranodal lymphomas. The estimated incidence is about 0.4 to 0.5 cases per 100,000 people per year, but it rises significantly in immunocompromised individuals, such as those with HIV or AIDS or organ transplants. Secondary CNS tumors are more common than primary and occurs in about 5 to 10% of patients with systemic lymphoma, particularly those with large diffuse B-cell lymphomas, Burkitt's lymphoma, or mantle cell lymphoma. Primary CNS tumors is a disease of older adults with a median age of 60 to 70 years in immunocompetent patients. However, in HIV/AIDS patients, it tends to occur at a younger age, around 30 to 40 years old. Males are affected more frequently than females, with a male to female ratio of about 1.5 to 2 to 1. Geographically, the incidence is higher in North America and Europe, while regions high in HIV prevalence, such as Sub-Saharan Africa, have a greater burden of HIV-associated primary CNS lymphoma. Epidemiomas are a rare tumor that arise from epidermal cells which line the ventricles of the brain and the central canal of the spinal cord. These tumors can occur at any age but are most commonly found in young children and older adults. The exact cause of epidemiomas remain unclear, but research suggests a combination of genetic mutations, molecular signaling abnormalities, and potential environmental influences. Let's explore the key factors involved in the development of these tumors. They are not typically associated with inherited genetic syndromes, but certain genetic alterations may play a critical role in the development. The tumor microenvironment also plays a role in formation. Researchers have identified inflammatory pathways and abnormal blood vessel formation that may contribute to the tumor progression. Unlike some other brain tumors, they do not typically respond to immune checkpoint inhibitors, suggesting that they evade immune detection through unique molecular mechanisms. Unlike many other cancers, they have no strong links to environmental exposures such as radiation, chemicals, or infections. However, prior exposure to therapeutic radiation, particularly in childhood, may increase the risk for developing secondary ependymomas. Ependiomas are relatively rare, with an estimated incidence of 0.3 to 0.5 cases per 100 people per year worldwide. While they can develop in both children and adults, they are more common in pediatric and older adult populations. In children, ependiomas account for about 5 to 10% of all pediatric brain tumors, making them the third most common brain tumor in this age group. The majority occur in the posterior fossa, which classify them as posterior fossa ependiomas. In adults, they're more frequently found in the spinal cord, representing 60% or more of spinal cord tumors in this age group. They have a bimodal age distribution, primarily affecting children under 5 years old and adults over 40. Patient immobilization is critical for accuracy in cranial-spinal radiation. Not only do immobilization devices used ensure reproducibility, but it entails that we are accurately treating the tumor while sparing critical organs at risk. Without the proper setup, immobilization devices can cause discrepancies in treatment fields and gap or feathering points. Typically, a thermoplastic mask is used to secure the head, while a vacuum cushion or a full body mold stabilizes the spine and pelvis. A customized headrest ensures comfort and consistency across treatments. Depending on the patient, supine or prone positioning may be used. The cranial-spinal axis includes the whole brain, spinal cord, and cerebrospinal fluid pathways. Treatment borders are meticulously planned to ensure adequate coverage while minimizing exposure to healthy surrounding tissue. The most common technique uses lateral pulse fields for the brain and intracranial cerebrospinal fluid spaces from the posterior orbits down through the upper cervical spine. Shielding must be used to cover the anterior lobe, pharynx, and neck. The superior border extends to cover the entire brain, including the meninges. The inferior border usually ends at the S2 vertebrae, where the spinal cord terminates. The lateral border ensures full coverage of the spinal column while limiting unnecessary exposure to lateral structures. Field matching is critical to avoid hot or cold spots between the cranial and spinal fields. The isocenter placement requires special attention due to the junction between the brain and spine fields. The brain's isocenter is placed at the midplane of the head, while the spinal isocenter is typically placed among the midline of the vertebrae. Feathering techniques or junction shifts are used to prevent an overlapping dose of hotspots at the field junctions, ensuring a uniform dose distribution all across the cranial-spinal axis. A crucial part of planning is sparing critical structures while maintaining effective dose coverage. Eye lens or shielding are used to reduce radiation exposure of the eyes. The thyroid and heart is closely monitored as they are sensitive to the radiation, while lungs and kidneys are carefully considered when setting treatment margins to minimize toxicity. Precise treatment planning ensures that critical structures receive minimal radiation while achieving therapeutic tumor control. The treatment couch can be angled a few degrees to compensate for the divergence of the beam inferiorly into the spinal cord. Extensive treatment plan mixed beams of photon and electrons with compensators further demonstrates the importance of sparing organs at risk. Key treatment dose parameters include the field size and SSD. The spinal fields are treated with an extended SSD to accommodate the full length of the spine. To match the divergence of the beam of this extended distance treatment is the reasons why we use a brain in the spinal isocenter. Adjustments can be made at the junctions to optimize field matching. The collimator can be angled on the brain field to match the divergence of the superior margin of the posterior anterior spinal radiation field. Standard treatments typically deliver 23.4 to 36 gray and 1.8 gray fractions with a potential boost to high-risk areas. Each parameter is carefully calculated to ensure that consistent and safe dose delivery is across the whole cranial-spinal axis. Cranial-spinal radiation is a technically demanding but highly effective treatment for central nervous system malignancies. By following precise setup procedures, accurate isodose placement, and meticulous dose planning, we ensure optimal outcomes while minimizing risk. Thank you for watching, and we hope that this breakdown helps deepen your understanding of this complex radiation therapy technique.